Now, in Sheffield, we're very fortunate to work with two cardiologists who are specialised in inherited cardiac conditions, Professor Nigel Wheeldon and Dr. Oliver Watson, both of whom are here with us today. They both, I think, regret the fact that I have their telephone numbers and their emails, and I see they're laughing. I have contacted both of them when they've been on annual leave before, and they've very politely said, in the case of Dr. Watson, well, I am on the beach in Devon with my family, but yes, what was your question, Glenda? Professor Wheeldon, I think I caught in the garden once on a weekend, yes. Professor Wheeldon is going to speak to us today about arterial aneurysm and dissection, investigation and management.
Thanks, Glenda, for the invitation. I realise that people here are at different points in their journey with vascular EDS. Some are just coming into this, and others are actually experts and pretty much know as much as we do about it. I'm going to pitch this at a basic level, so the experts, if you'll excuse me doing that, because I think it's important, as Diana said, to make sure that everybody knows the fundamentals. And besides, I do simple very well. I'm not as clever as Dr. Johnson, I'm a cardiologist, so this is my thing, simple is good. So let's first of all just consider the artery itself. So people think of arteries a bit like pipes in their central heating system, inert structures that just transmit the blood. Nothing could be further from the truth. These are living structures that change and evolve over time. So if you just see the big picture under a microscope of an artery, you've got the lumen in the centre which carries the blood, and the arterial wall, which we'll see is made up of different layers, and that's quite important. So if we take a section through the arterial wall and look at it in more detail, you'll see this, and it's made up of essentially three layers. The biggest one being the so-called media, the middle layer of the artery. But on the inside, next to the blood, there's something called the intima, a very thin layer, a few cells thick, with some elastic tissue, connective tissues that we talk about, which then leads straight onto the media, the thicker muscular layer, full of smooth muscle cells. And then on the outside, there's a covering, the so-called adventitia, which is again connective tissue, of which collagen is part. So collagen is throughout the arterial wall, and hence if there's an abnormality with collagen, you expect that abnormality to show itself in the arteries. Okay, so some basic principles and ways that we describe things. You hear a lot about aneurysms. Aneurysms are essentially localized dilatations of arteries. And typically they have to be at least 50% bigger than the rest of the artery to be called an aneurysm. And you'll see these various types of aneurysm, this so-called fusiform, which is quite common, where the artery dilates in one place. There's clearly some inherent weakness in the artery at that point. Others form little sacs around the edge of the artery, so-called saccular aneurysms. And the problem with aneurysms is that they tend to get bigger. They don't have to, we monitor some, they stay the same forever. But once they get over a certain size, then the wall stress becomes higher, and they have a tendency then to go on and become bigger, which we need to know about. A rupture is a slightly different issue, of course, in that there's been a breach in the arterial wall allowing blood to go to the exterior, and that might be into a cavity or into a muscle or an organ. That's fairly self-explanatory. But I think the one that people find difficult to understand is the dissection of an artery, which is a splitting of the wall of the artery and blood enters the layers of the arterial wall. Our arteries are fantastic things, of course. They start at the heart and they go all around our body to our various organs and get smaller and smaller. And you have some of these fantastic arterial structures going to organs. Eventually, of course, going down to tiny capillaries to deliver the oxygen to all the tissues and then joining up to form the big veins. And I'm just going to focus on the arterial side of the system, although we've heard that vascular EDS can involve the veins as well. So Dr. Johnson described where we tend to see dissections. The distribution of aneurysms is slightly different to that, and this is just from about 80 odd patients, and you'll see that there's a predominance in such places as the gut arteries and in the aorta, and in slightly unusual places such as in the leg or the arm arteries. And I say unusual because we tend to think of genetic arterial disease in terms of the common syndromes that people talk about, for example, Marfan's syndrome. And in Marfan's syndrome, it will typically affect the aorta, but it will not affect other arteries around the body, whereas vascular EDS typically involves arteries elsewhere. So the issue of arterial dissection, I've showed you that the arterial wall is made up of various layers, and when a dissection occurs, there's a breach of the internal lining of the artery. There's an inherent weakness. And of course arteries are all under pressure. That's a problem that we have with arteries. We can't have zero pressure in our arteries. So this is a sort of, it's not a design fault, but you can see how it aggravates the problem. And the breach occurs in the wall of the artery, but instead of rupturing the artery as it might, it actually gets into the layers of the artery, a bit like a skin of an onion, gets between the various layers, and the pressure then forces the blood into a so-called false lumen. And if you look at this schematic of the false lumen occurring, and we compare that with the microscopic histological structure, you can actually see here a physical hole, cleft, plane in the artery where the blood has rushed through to cause a dissection. This is another way of looking at it. The internal lining of the artery has been torn away. Bear in mind, you may be talking about a few millimetres here. This is not a great big structure necessarily. And it allows the blood to go backwards down the arterial wall. So we have the true lumen where the blood should go, and then the false lumen where the blood is actually going. And in many cases the false lumen becomes the dominant lumen. It's bigger than the true lumen. And the problem we have with this is that not only is the artery torn internally and weakened with the potential to rupture to the exterior, but the true lumen, where the blood should go, is narrowed down. And therefore the organ or tissue that should be getting that blood could be compromised. Also, when there's a dissection in an artery, the flow is disrupted, and it's a substrate for clotting to occur in the artery. So you can get little blood clots forming around the dissection, which can then travel down the artery and cause a problem in that particular organ. So that's the sort of basics of aneurysm, dissection, rupture. And just want to make it clear to you the sort of investigations that we use, and many of you will have been through one or more of these. Perhaps the simplest is vascular ultrasound. So baby scans, kind of thing. And here, for example, is someone having a carotid ultrasound scan performed. And we can get some very, very nice pictures. This thing here is the artery, and the black area is the blood. So it can be very, very good vascular ultrasound, but it lends itself to structures that are near the surface. So the neck is great, perhaps the leg, some of the arm arteries. You can scan the aorta in the abdomen, a little bit less clear, but nevertheless very good. Heart scans actually only show a relatively small part of the aorta, so they're not fantastic for showing the rest of the aorta that you might want to see. That's vascular ultrasound, and we use quite a bit of this. More likely you'll get an MRI scan, a magnetic resonance imaging scan, and this can be used specifically to look at the arterial system. And you'll notice here that this is more of a tube type scan, so people sometimes feel a little bit compromised going into a tube, a bit claustrophobic, but nevertheless it provides us with very useful imaging. And the benefit of this is it's magnetic, it's not X-ray. So theoretically at least there's no discernible harm to the patient. And you can use this scan repeatedly over the years, which is why it's very, very helpful. So we have no concerns at all about doing annual scans in people, which can be quite extensive. And we get these sort of images of the arterial system. This is the carotid and brain arteries. So for a non-invasive test, you can actually get some very, very nice images of the arteries. It's also quite good for giving you an overview as well, whereas ultrasound tends to be very focused. This gives you the big picture. CT scanning is similar, slightly different. The scanners tend to be more of a sort of polo mint type, so you feel less enclosed within them. But of course CT involves X-rays, which we know over many years can become an accumulative problem and have a certain risk. So we don't use CT all of the time. We don't use it for routine surveillance scans. We tend to use it where we need specific detail. Perhaps something is shown up on the MR scan that's not quite clear, or on an ultrasound scan, and a single CT of that area is a pretty good trade-off to get a nice clear picture. So here's a CT, for example, across the thorax. All the stuff in the middle is the heart and an enlarged aorta. And CT is particularly good for showing dissection. So here you have the so-called tennis ball appearance of the aorta. So here's the aorta, and you can see this line across the aorta, which is actually the flap of the dissection. And the arrow is pointing to the true lumen, where the blood should be flowing, and yet the biggest part of the aorta is now the false lumen as a result of the dissection. So CT can be very, very helpful in acute aortic dissection. And some clever things are happening nowadays. You can reconstruct images and produce these sort of 3D animations to show things like this, an aneurysm forming on the brain arteries. And in fact, we are now in a world of artificial intelligence and virtual reality where you can literally walk your way around arteries. So it's pretty fantastic stuff. Here's a reconstruction of the abdominal aorta and the blood supply to the kidneys. It's all very nice. Invasive angiography is used a lot. I do a lot of it for the coronary arteries, but it can be used for any artery. But this involves putting catheter tubes into a peripheral artery, usually leg or arm, and then passing tubes up to the territory in question and injecting contrast dye, taking X-ray pictures. So not only is it X-ray based, it's invasive, and of course we know tissue fragility is a part of vascular EDS, so we try and steer away if we can from invasive procedures, but occasionally they still have to be done. And so you can get some very nice pictures by doing the angiogram and then subtracting away all of the other tissues, so you're left just with a picture of the arteries. Here, for example, is the brain from the side and from the front, showing this big aneurysm. So they can be very nice, clear pictures. And here, for example, is a carotid artery with a dissection. So here you can see the white line going up the artery. Maybe compare it with this normal artery here, which is all black from the contrast. So this white line extending up the carotid is a carotid dissection, and a few months later it's largely healed of its own accord, just leaving a slightly irregular artery. And carotid dissection actually affected a professor of cardiology a few years ago who presented with severe pain in the left side of his face and his eye, and he was actually on call operating in the night whilst he was having this pain without knowing what it was. And only the next morning did he have an MRI scan to show he had a carotid dissection. And I can say that with some authority because that was my dissection. Yeah. So I can see this from both sides. So fixing things, well, you'll hear a lot about stents in the general sort of arterial world. Stents are applicable to vascular EDS, although we do try and steer away from them as much as possible because of the need to get into arteries in the first place, that invasion of the vasculature. But stents are essentially stainless steel structures, usually very small, going down to 2 millimeters, but can go up to 20, 30 or more millimeters. Some of them are deployed on balloons. So you put the balloon and the stent into the artery, expand the balloon, it expands the stent, you deflate the balloon, pull it out and leave the stent where it is. And you'll see the stent can support the arterial wall, and it can actually plaster back any dissection that's occurred. So they can be very, very useful in certain circumstances. And you can see some of them are really very big and can be used in the aorta to cover aortic aneurysms and dissections. And of course the surgeons have their role as well. If they have, in this case, the aortic root, they can take out the enlarged area, replace it with a surgical graft and fix up the artery in that way. But again, you have the invasion of a big operation, which we try and steer away from. People ask about blood pressure. Every time our heart beats, our blood pressure shoots up, and you get this peak systolic blood pressure, and then the background diastolic blood pressure. So we always have pressure in our arteries. And of course, every time the heart beats, this pulse wave goes down the arteries expand, and then they recoil because they're elastic, and you get a stress on the arteries, which we have all the time. But as we exercise, our blood pressure goes up. If you start at a relatively normal blood pressure down here, on exercise you can be well into the hypertensive range. If you start high already, you can go to well over 200 millimeters of mercury, which would be regarded as very high. So most people with vascular EDS don't have hypertension, but if they do, we want to treat it very rigorously. But we also try and get people to get their blood pressure down in the normal range as well. And beta blockers are very helpful in reducing blood pressure, particularly when you exercise. And many of you will be familiar with beta blockers. They all end in ol for some reason. Celiprolol is part of this as well, and many of you will be taking them. You'll also perhaps be familiar with the sartans, losartan in particular, which also lower blood pressure. But actually, the sartans tend to sort of stray into a territory, which I'm going to just mention on my last slide, where they have independent effects on the arterial wall. And we've seen some promising data in scientific and some clinical studies for both sartans and beta blockers. This is my last slide, and my only complicated slide. And this is about how the artery looks after itself. So the arterial wall is dynamic. It's not just a central heating pipe. It's continuously looking at itself, replacing itself. And all of the matrix, the connective tissue area around the muscle cells is being replenished. And that happens by cell signaling. You'll hear this term signaling if you go looking in the literature. And it's all about the outside of the cells telling the cell what it needs. It may be in response to stress or changes in metabolism, but there are special signaling systems that come from the outside, go into the cell, to the nucleus, which codes for all the proteins, saying, we want some more of this or some less of this, and the nucleus can then activate the cell to produce those proteins. So in simple terms, it's signaling in, proteins out. In reality, there are hundreds of molecules that are involved in that signaling process. And these two stars here represent where I sort of see the future. We all need surgeons, and we're going to need them well into the future, but actually they're not the future. And we all need interventionists putting stents in, but that's probably not the future either. I think the future is trying to protect us against the inherent weakness in the arterial wall in the first place, and we're going to do that probably by looking at ways of affecting the signaling process that goes on into the cells, or even the genes themselves, gene therapy. So I'm not going to say any more about that because I think you can get some good talks about research later on today. So lifestyle, you hear about, it's important. Control of blood pressure surgery is a part of that. Medication for sure. Awareness we've heard about with Dr. Johnson, report things early. Arterial problems tend to occur very suddenly. We only intervene if we really need to, otherwise we try and manage it conservatively. Just like I did with my dissection, just to prove that it can work, and I'm still here. Research is going to be really, really important, and if you get a chance to go into research trial, look at it very carefully. Thanks very much.